Hello everybody, Dr. Gavin Gardner here with another short video where today we're discussing a topic so interesting I'm sure that it will take your breath away. Because today we're discussing the pulmonary embolism rule-out criteria, otherwise affectionately termed the PERC Rule. If you didn't already know, the PERC Rule was created by Dr. Jeff Klein, who is the premier all-around guru of all things pulmonary embolism. So what Dr. Jeff Klein did was took 3,148 patients from 10 different sites, and they identified 21 potential variables that might help us to identify patients with pulmonary embolism. Of those, they found 8 that would be best suited for a rule-out criteria. They went on to validate their study and found that their sensitivities were very good, and their false negative rate at 90 days in a low-risk patient was 1.4%, meaning that at 90 days in a low-risk patient, their miss rate was 1.4%. This is important because as a general rule, our acceptable miss rate before we initiate testing is 2%. So that means for a patient in the emergency department who is at low risk for pulmonary embolism, if I apply the PERC rule and they do not meet any of the criteria, that places them below the 2% level of risk, and therefore I don't have to do any additional testing. 4 years later, they did a second multi-center validation using 8,138 patients from 13 sites. To this, they added physician gestalt. Basically, they said that the ER physician should have a pretest probability of less than 15%. So they thought that the patient had a less than 15% chance of having a PE. They found the false negative rate for this study at 45 days was 1%. So it should go without saying that the PERC rule seems to be really good. So good, in fact, that you almost get the same appreciation for the PERC rule as you do watching an orthopedist trying to read an EKG. Many of us had hoped that the PERC rule would be good enough that we would finally see the death of the D dimer. Unfortunately, the D dimer seems to have escaped its fate and lives on today. So what are the different pieces of the PERC rule puzzle? Age greater than or equal to 50, heart rate greater than or equal to 100, O2 saturation on room air less than 95%, unilateral leg swelling, hemoptysis, recent trauma or surgery, prior PE or DVT, or hormone use. So let's go through these really quickly. First of all, you have to decide that this is a low-risk patient before you start applying the PERC rules. Second of all, the PERC rules are rule-out criteria. If they're PERC positive, that doesn't mean that they have a PE. You just can't rule them out with the PERC rules. Number 1 is age greater than or equal to 50. Number 2 is a heart rate greater than or equal to 100. So that means if the triage nurse documented a triage vital sign of a heart rate of 102, even though they've been a heart rate of 66 the whole time they were in the ER, that person is still PERC positive. Same thing goes with oxygen saturation. If they document anywhere on the chart that the patient has an oxygen saturation of less than 95%, that is a PERC positive patient. Number 4, unilateral leg swelling. That should make a lot of sense. If they look and smell like they've got a DVT and they've also got symptoms and signs of a PE, well, that should all make sense to you. Number 5, hemoptysis. Number 6, recent trauma or surgery. It always makes me laugh when they put this word recent in there, but they don't define that at all. Recent trauma or surgery means trauma or surgery or hospitalization within the last 4 weeks. Number 7, prior PE or deep venous thrombosis. And number 8, hormone use, whether they're on estrogen or testosterone, place them at greater risk for PE. So obviously that makes the list. All right, now you know all about the PERC rules. Simple and easy to apply in the clinical setting. Maybe next time we can discuss the utility of shoe covering during fecal disimpactions. I hope that you found this short video useful, and it was my pleasure bringing you this educational material.